Hi, my name is Kirstin Pickens. I'm Dr. Howard Harris's PA. I've been with him since 2005. We came up with this joint replacement camp so that we could spend a little time kind of preparing you for your upcoming surgery. One of the worst fears is the fear of the unknown, and so that's what I want to try to address today. Try to give you as much insight as possible into how to prepare, how to best prepare for your upcoming surgery, and kind of what the expectations are leading up until the time you come in for your first post-op visit. So as you watch this video, you'll see I'm going to talk about three things with you. First of all, I want to spend a little time talking about what shoulder arthritis is and what the joint replacement will look like. I want to also talk about to prepare you for the days leading up to surgery, what's going to happen on the day of surgery, and then a little bit about how to best get through those next days after surgery until you come in for your first post-op visit. And lastly, I want to try to give you as much information as I can to try to help you, equip you with the tools to help with your pain after surgery. So we'll start right in with what does it mean to have arthritis? Well, we're born with nice smooth cartilage on the ends of those bones that make up the shoulder joint, the ball and the socket. And over time, you can either wear it down or you can have injuries that result in the loss of that cartilage. And when you lose the cartilage, that's when the shoulder becomes painful and you have the painful popping, etc. And so Dr. Harris will remove those surfaces of the joint and replace them with the new prosthetic, which relieves the pain and helps you get back your mobility and get back to life. And you'll see that in this slide here. There are two types of replacement. There's either what we call the anatomic or conventional, and that's replacing a ball with a ball and a cup with a cup. Or if there's any concern that not only you have arthritis, but you have a problem with your rotator cuff, then you may have the reverse, which is what you see on the right. And that replaces a ball with a cup and the cup with a ball. And what that does for patients with arthritis and a rotator cuff repair is give them better stability of the shoulder, not just get rid of the pain. Move on to the next slide. So preoperatively, prior to surgery, the hospital will have you come in. Potentially, they may call you on the phone, but most of the time they'll have you come in. So when you go on that day, make sure you wear something comfortable. They may perform an EKG, hence wearing a comfortable shirt that's easy for them to get in. You don't have to take the shirt off. They can just reach around and put the leads on. They may have you do a chest x-ray, and they may have you do labs. If you do have to do labs where they draw blood, don't worry, you don't need to fast. However, if you are diabetic, it's better for you to try to eat as best possible that day so that your blood sugars are not high when we get those labs. They'll also want you to take your insurance card, your driver's license, living will, power of attorney, and if you would, take in an up-to-date medication list, or sometimes it's just as easy just to take your medication bottles in, because that way if something has changed, it's going to be correct on that bottle. To help you prepare for surgery, one of the things that we need your help with, whenever we do surgery, there's a risk of bleeding, and we try to do everything we can to reduce that bleeding during surgery. But there are some things that you can do to help us as well. There are certain medications that we'd like you to stop at least a week prior to surgery. Those include aspirin, non-steroidals, which are Advil or Aleve, also known as ibuprofen and naproxen. Motrin falls in that category as well. Also, if you're on Coumadin or heparin, go ahead and you need to talk to the doctor that put you on those so that they can tell you when to stop them and when to restart them, and if there's anything you need to take in between. There are also some herbal medications that can increase bleeding, which some of them are ginkgo biloba, CoQ10, vitamin E, garlic, turmeric, ginger, green tea, and fish oil. So all of those, if you would stop at least a week prior to surgery, that just reduces how much bleeding you might possibly have and makes your surgery go a little easier. Physical therapy is also something we like you to prepare for. So prior to your surgery, if you will find a location that you'd like to go, and when you scheduled surgery, the surgery scheduler in your packet gave you a list of physical therapy locations that we've used in the past that have been good places for our patients to go. Now, what I would tell you is, if you don't know of any place, I would choose one from that list. However, if you've used a therapist in the past that you really liked, go ahead and use them. You want somebody that you're comfortable with and that somebody that's close to home. Some therapy locations want you to have a prescription prior to the surgery so you can get scheduled. Also in your packet, your surgery packet, there is a generic therapy script that you can provide them. However, once the surgery is done, we're finished with surgery, one of my jobs is I will write you a specific prescription based off of what was done for your surgery. You'll get that on the day of surgery, and then all I'd ask is that you take that with you on your first day of physical therapy, which is usually the day after surgery. I know that sounds terrible right now, but most patients really enjoy going to therapy that first day because the therapist can help you with things like the cold therapy and the TENS unit. They'll also help you adjust the sling as needed, and they do just a few little exercises that first day, but we'll talk about therapy more here in a little bit. The key is get an appointment for the day after surgery or within a few days after surgery in preparation for the surgery itself. Now, I want to take a little time just talking about the things that we do to try to help prevent infection. One of these is a newer, if you've had surgery with us before, one of these is something that we have just started. And so about 2 weeks prior to surgery, we will call in a prescription to the preferred pharmacy that you have here at the office. We'll send in a prescription for what's called doxycycline. And you're going to take that 2 times a day for the first 2 weeks prior to surgery. So the 2 weeks leading up to your surgery, twice a day you're taking doxycycline. That's been shown is it helps to reduce infection, and there's also some evidence that it may actually help in the healing. So again, we'll start that. If you have any issues or problems with that, please call the office and we can discuss that further. One other thing that we do is benzoyl peroxide. So the risk of infection with a shoulder replacement is less than 1%. However, it's not 0. So the doxycycline, along with something called benzoyl peroxide, is something we use prior to surgery. The most common infection in shoulder surgery is caused by a bacteria that is an acne bacteria, just like what you can get on the face. And so they've shown that let me back up. So benzoyl peroxide or acne is not only found on the face, but it's also found deep in the pores on the shoulder. And it's been shown that if you use the same medication, the benzoyl peroxide they'll use on the face, if we use that on the shoulder, they can actually reduce the amount of bacteria in the shoulder. So when we make that incision, there's less opportunity for that to get in. So for 3 days prior to surgery, that's going to be 5 applications, you will use the benzoyl peroxide to help clean the shoulder. Now, we've provided you a sheet with directions on how to use that, but let me just kind of briefly go over it. If your surgery is on a Thursday, you would start this Monday night, and basically you take let's say, for example, I don't shower at night, I shower in the morning. So if I started this Monday night, I would take about a $half size amount of that benzoyl peroxide, and I want to rub it all around the shoulder, in front, up top, along the side, and along the back, and allow that to dry. And benzoyl peroxide is a peroxide, so be careful what you put on afterwards. Really let it dry, but I wouldn't put on your favorite t-shirt or nightgown because it could bleach that. I'll also say that some people have said that it can bleach their sheets or their pillowcases. So again, don't have your favorite things down just in case it happens. So you do that Monday night. I would get up Tuesday morning, take a shower, then apply it again letting it dry, and dressing. And then, so I've done it Monday night, Tuesday morning. I'll do it again Tuesday night, Wednesday morning, and Wednesday night. So that's my 5 applications, and I'm done. my surgery is Thursday morning, I'm not putting it on Thursday morning. And so that again helps reduce the load of bacteria on the shoulder that will help you prevent infection even further. And then of course, the thing that we've always done is IV antibiotics. So when you get to surgery and they hook up your IV before the surgery, we will give you a dose of antibiotics through your IV, do the surgery, and once the surgery's done, you'll get one more dose of antibiotics prior to leaving the surgery, but it's all through the IV. You won't go home with any oral medications for antibiotics. So that's part of what we do for infection prevention. So that's all leading up to the surgery. On the actual day of the surgery, again, wear a comfortable, loose-fitting shirt. It's not important to getting to the surgery, but once the surgery's done, you're gonna have a sling on, you'll have dressing and everything, and so you want something that's gonna be easy to get on. I usually suggest a button-up shirt, a larger button-up shirt, because you could just easily slide that arm in and then get it on. But a big t-shirt or sweatshirt works just as well. Just something that's has a little more give to it, makes that easier to get on. The hospital usually has you there at least 2 hours prior to surgery. Know that they will not call you until the day of surgery to tell you what your surgery time is and what time to be there. We don't do that to be inconvenient to you, but we do it because surgeries change, even sometimes up to the day prior to surgery. And so the last thing we want is them to call you multiple times to give you that information. We'd rather just have them call you once and avoid the confusion. Once you get there, you'll check in at the reception desk, and then a nurse will come to take you back to the operating room, to the pre-op area, to change you into your beautiful gown, start an IV, let you go to the bathroom. There'll be multiple people coming in to check and ask you about medications and which side's being done, who's doing your surgery, what's being done. And then you'll have an anesthesiologist come in and talk to you about the surgery itself. First of all, it is a general anesthetic, meaning you'll be completely asleep through the surgery, but they'll also talk to you about a nerve block. And so to tell you a little bit about the nerve block, basically they're gonna put numbing medicine in and around the nerve that provides the motor and sensory function for the arm, so that for at least 8 to 12 hours after surgery, you probably will not even feel that arm, which is obviously great for pain control. Everybody's a little different how long that lasts. A lot of it's based off of how fast your body breaks down the medications. But let me explain a little bit about the nerve block itself. First of all, they will give you some medication that you probably won't remember having it done, but what they'll do is they'll take a probe, a little ultrasound probe, and they'll put it around the base of the neck where the nerve that provides that sensory motor function is found. They'll find that nerve, they'll take a needle, they go right down to that nerve, and they inject in numbing medication. And it takes a few minutes, but that numbing medication will work its way down, all the way down potentially to your hand, to the point where you don't feel the arm. Not only does that help you after surgery, but also helps you through surgery. Whether you realize it or not, your body can sense pain even when you're under anesthesia. And as your body senses pain, one of the things that can happen is your blood pressure can rise. And that requires the anesthesiologist to have to give you more medication. And so the less pain you have during the surgery also means less medications that you have to have, which makes it easier for you to wake up, etc. So I want to go back and talk a little bit more about the nerve block. It works great, and like I say, some people will not have any pain at all, and you're thinking, oh, this surgery's great, I'm not going to have any pain like people talked about. But if you're not careful, when that block wears off, you can go from a 0 out of 10 with pain to a 10 out of 10 if you're not prepared for it. And so as soon as that block starts wearing off, you want to take pain medicine. Well, how do I know that that's wearing off? When they do the block, it actually numbs from the shoulder and works its way down to the hand. And when it wears off in just the reverse. So when you are able to feel your fingers or move your fingers, or you start feeling it go up your arm, you want to start taking pain medicine. Now, Dr. Harris typically prescribes hydrocodone for pain medicine. If for some reason you have an allergy to that, we should know, or if you have any other issues with it, then please let us know ahead of time so we can make and give you a different type of prescription. But I'll use hydrocodone when I talk about it in this presentation, just for reference. But you want to start taking the hydrocodone as soon as you can start feeling your fingers, or you can move your fingers, because I've had people say that it took hours for that block to wear off all the way back to the shoulder, and some people that felt like it just took minutes for that to happen. So again, start taking that pain medicine right away. At that point, you can also start using your TENS unit. So even though I place the TENS pads on you at the time of surgery, you don't want to use the TENS unit until the block wears off. Now, the next slide is again talking about the pain. Even if you do all the things that we talk about in this presentation, there are still sometimes that pain can be unmanageable. For most patients, the most severe pain is the first 2 or 3 days. Night pain can last up to 2 to 6 weeks, so don't be surprised by that. But most of our patients are off of pain medicine during the day within a week of surgery. The key is we've got to keep it under control and get you down to a level that you don't need it. And so even if you do all the things that correctly, you still may get behind. And so I want to kind of explain to you a little bit about what to do with this, because the last thing you want is to be 3 o'clock in the morning and trying to determine what's the best way to help get your pain under control. So if the way the pain medicine is written is you can take 1 every 4 hours as needed, or if that's not enough, you can take 2, but you should stretch that out to every 6 hours. And that's in part because of the pain medicine itself, but also that pain medicine has Tylenol in it as well. And you're only allowed, or you should only have up to 4,000 milligrams of Tylenol in a day, or else you're going to start affecting your liver. And that's the reason why the pain medicine is written as it is. However, if you get home and in that first day or night or the next day, your pain, despite everything else we're going to talk about, if your pain starts getting to a level that is not managed by the 1 every 4 hours or the 2 every 6, what you can do for just a 24-hour period only, but if you need it, if your pain is to, that 7, 8, 9, 10 out of a 10 pain, if you need to, you can take 2 of the pain pills every 4 hours. Okay, so that's only for the first 24 hours. But believe it or not, every now and then, even the 2 pain pills every 4 hours is not enough. And so in that situation, if that 2 every 4 hours is not enough, take 2 pain pills. 2 hours later, you can take 2 of the 200 milligram ibuprofen. Now that's Advil. And the reason I say ibuprofen or Advil rather than Aleve, which is also naproxen, is because you can take more of them in a 24-hour period. So you take 2 of the pain pills. If you need it, 2 hours later, you can take 2 200 milligram ibuprofen, and then 2 hours later, it's time to take the pain pills. And so you can continue to alternate that every 2 hours as we were talking about it, until you get your pain to a more manageable level. And as soon as you do that, start backing off of that pain medicine. Start stretching out the time, start reducing the number of pills that you're taking as you can tolerate it. If for any reason you're getting, let's say it gets to 7, 8 o'clock in the morning, we're back at the office. If that's still not seeming to manage your pain, then call us. And we can try to help talk you through or come up with a different plan. But for most patients, within about 8 to 10 hours, that really starts getting it back to a more manageable level, and then you can get to a more normal schedule with the pain medicines. Now, physical therapy. So for the first couple of weeks, you may want to take a little pain medicine before you go to physical therapy. But I would ask that after the first week or two, if you're still taking pain medicine, don't take the pain medicine before you go to therapy. Now, some therapists may ask you to do it, but the reality is pain medicine makes you think you don't have pain. It doesn't get rid of the pain, it just makes your brain think that you're not having it. And so what I don't want is for you to take the pain medicine, go to therapy, and yes, they really get you stretched good, but by the time you get home, that pain medicine is worn off and your shoulder realizes that it's done more than it should. So what I prefer is go to therapy, let them push you as much as you can within tolerance, and then if you get home and you've done too much, then take the pain medicine. So again, that's just for the first couple weeks. If you need to, take a little bit before, but after that, we prefer you not. One other big thing with pain medicine is that it can be constipating. And for some people, it can be very constipating. And what we don't want is for you to have any kind of bowel issues along with dealing with the shoulder. So if you already know you have problems, a couple simple things: drinking lots of water, getting up and moving around. But I'd also suggest taking a stool softener to try to help putting more fiber in your diet. Anything you can to help your bowels so that you can have a more normal bowel movement. The other thing I'll say is if those things aren't working and you've gone 2, maybe 3 days and you've not had a bowel movement, don't hesitate, call the office. And again, we can walk you through the steps of what we should do next, because that can be an issue that can lead to more problems down the road. So just be aware of that. A lot of patients, if you've not taken pain medicine before, aren't aware how constipating that pain medicine can be. Now, pain medicine is just one of the ways that we try to help with pain. There are some other things that I think are just as good, if not better, long-term for you. One of them's the TENS unit. And if you choose to get a TENS unit, basically think of it as a brain distractor. It's got the little electrodes that are placed on the shoulder around the muscles. It causes the muscles to twitch, which in turn makes your brain focus on the twitching instead of focusing on the pain. And again, that's something that you don't want to start until the block wears off, because of the fact that it does work off sensation. But as soon as the block wears off, you can start using it. You can use it for as long as you like. If it's helping with your pain, the way it's set up is it usually runs for about 30 minutes and then it turns itself off. If your pain is gone, you don't have to turn it back on. But if your pain comes right back, just set it and start it again. Check your skin. You want to make sure, especially those of you who have more sensitive skin, make sure that those pads aren't irritating your skin. If so, you may need to give your skin some relief, but you can use the TENS unit as much as you want. However, if it is not helping with your pain or you're not having pain, you don't have to use it. It doesn't help with healing. It doesn't help with swelling. It is only there to try to help with pain. Don't worry. You can't hook it up incorrectly. So again, I place the pads on you, on the muscle. There's not an exact location they have to be. I try to stay off of bones and I try to stay off of the incision. But other than that you don't have to do anything else with it. The other is you'll find there's 2 leads, each with 2 probes on there. And so the company suggests hooking these 2 up with 1 lead and 2 probes, and then the front and the back with the other lead and the probes. Now I have another little section with the video that I'll tell you a little bit more about that a little bit later if you want some more information on the TENS unit. But again, remember, it's a brain distractor. It's only to try to help with pain. Use it if you need it as much as you want to. If you feel like it's not helping, you don't have to use it. But this other thing is the cold therapy. And it's the one that I think is of the most benefit. Pain medicine, although it works well, it has a lot of side effects. And cold therapy is a way to really try to get at the pain itself. And the way this works is the more ice you can keep on your shoulder, the more swelling you can keep down. The more swelling you can keep down, the more pain you can keep away. You probably were talked to about the cold therapy unit when you sign up for surgery. And basically, it's a large pad that fits over the shoulder. It comes with a little unit that houses ice and water. It keeps a constant flow of that to the shoulder itself. And I like it because it covers a large area. Keys with it, make sure you keep something between it and your skin so that you don't get frostbite. That's the big concern with this. Now, the cold therapy is one way to do it, but you can use ice packs. You can use a bag of frozen peas. I don't care how you get ice on your shoulder, just get ice on your shoulder. If you read the book on how long to put ice on your shoulder, it would say about 20 minutes every hour. But I'm going to tell you to keep ice on your shoulder as much as you can. Because again, the more you keep the swelling down, the more you keep the pain away. And the only problem is just making sure you don't get frostbite. So keeping something between whatever cold you're using, and that is the best way to avoid it. You can purchase a cold therapy with us. You can check on Amazon, check your friends, and see if they have one that you can borrow. Or like I said, just a gel pack or ice pack or bag of frozen peas. But again, keep that ice on as much as you can, and that will help keep the pain down. Especially in the first couple of days, I'd suggest do it as often as you can. And then after that, then we'll talk about as you come in, using it after therapy and before you go to bed to try to help with any other pain that you have. So again, TENS unit cold therapy, tools in the toolbox to try to help with the pain beyond the pain medicine. So when the surgery's done, Dr. Harris will place you in a sling. And that is designed to give you some support, give you some comfort, and kind of help with the repair itself or the reconstruction itself. You need to wear that in the first few weeks all the time, except for when you're taking a shower or when you're at physical therapy. So sleeping, even in the first couple weeks, we want you to have that on. When you come in for the first visit, I'll help make some adjustments and we'll get you down to a smaller apparatus than what that big sling is. Something else that people used to call us about is bruising and swelling. Know that it is not unusual to have some bruising and swelling. Matter of fact, it won't happen that first day, but you may find it 2 or 3 days afterwards where everything looks normal, but 2 or 3 days after, then you start to notice the bruising. And that's because when you do bleed at the time of surgery, it usually takes 2 or 3 days to come to the surface. And then even then, it tends to be a little farther down the chest or the arm because gravity has pulled it down. Swelling, like we talked about with the cold therapy, you can help reduce the amount of swelling with the cold therapy. However, you still may swell. And some people, it stays right there in the shoulder. Other people, it goes all the way down the arm into the hand. And so if it goes into the hand, the therapist can help you with some things, but I'll also say just doing some simple squeezing with a ball, trying to elevate the arm, in the sling so that it's up above the heart and gravity can help pull it down. Those are all ways to try to help with that swelling, but know that that is not unusual. However, again, just like with anything, if you have any concerns that something's not normal, then give us a call and we can discuss it and make sure that it is normal or not. Sleep. Sleep can be a little challenging. Most people will suggest right after surgery they get better sleep in a recliner. And the reason I say a recliner is because you're in a more upright position. When you lie down flat, the shoulder tends to not like laying flat as well right after surgery. Again, you can sleep in bed as soon as you want. You just may not like sleeping in bed. And so think about a recliner. Now, the things I want you to think about with the recliner though is which arm did you have surgery on and which side is the leg rest on that side. So it may be a situation where, if you have somebody there with you, they can help you get in and out of the recliner. If not, there are, not to tell you to go out and buy a new recliner, but there are newer recliners that have some on different sides. You may want to have to consider a different way to sleep, in preparation for this. Some people like sleeping on a couch where they can lay sideways more in a lying position, but they can still prop the arm up and have a little bit of something that doesn't allow it to drop too far back or too far forward, which is what happens when you're lying in bed. You may have an adjustable bed. And if you have an adjustable bed, that works as well. You just want to put the head of the bed up higher. So again, you're in more of that upright position. The key is with sleep, find what works for you. There is no wrong answer. Believe it or not, you can actually sleep on the side that you had the surgery done on without fear of injuring the surgery itself. But I want you to listen to pain. If you roll over on that side and it causes pain, then that's your body telling you to get off of it. So find what's comfortable for you. Another suggestion, if the recliner doesn't work, if the couch doesn't work, and you don't have an adjustable bed, is if you've never seen it before, there are what are called wedge pillows. basically a triangle that is made of foam, and it puts up against your headboard, and it's on the bed itself, and then it lays you at a 45 or a 30 degree angle, so it mimics that same thing as if you had an adjustable bed, or you're sitting more upright like a recliner. Whatever you choose, just find the way that you can sleep the best. Again, it still may be challenging, even with all the things we're talking about. Like I say, some people, it takes 2 to 6 weeks before they're really getting comfortable sleeping at night. But sleep's too important, so find what works best for you. And everybody's so different with that. There's not one way that works the best out of everything. So the chance of getting a blood clot after surgery is less than 1%, but it's not zero. And for that reason, Dr. Harris is going to put you on an aspirin twice a day for 6 weeks because you're at the highest risk of getting that blood clot in the first 6 weeks. You can go ahead and purchase that now. It's over the counter. Let me suggest you get the kind that has the enteric coating on it. That way it's less upsetting to the stomach. I'll also say take it with food. It is the adult dose, or the 325 milligram aspirin that you want to get. You'll take one in the morning and one in the evening. If for any reason you have any history of bleeding ulcer or any other reason you should not be taking aspirin, let us know. Everything we do is to try to help prevent other problems. We don't want to create new ones. And so if you know that you should not be taking aspirin for one reason or the other, just let me know and we can adjust that. If you're already on another blood thinner prior to surgery, most likely we will put you back on that same blood thinner and you won't need to take the aspirin. But if you have any questions about that, we can discuss whether you should or shouldn't be on the aspirin. Again, for the first 6 weeks, enteric coated, 325 milligram, you can go ahead and get that now. So I told you the incisions, you'll have a dressing that is not only waterproof, but it has some antimicrobial properties. It can stay on for 7 days. We provide you with a second one that can be replaced so that you have complete coverage until you come in around 10 to 14 days after surgery to have those staples removed. So again, any problems you have with any of that, just let us know. But that's a pretty straightforward, like I say, just a nice simple dressing on there that holds on pretty well. So we talked about physical therapy, a little more detail about it. You're going to start that within the first couple of days of surgery, preferably the first day after surgery if possible. On that first day you go in, again, I will write you a more specific prescription for physical therapy right after surgery that gives the therapist more details about what Dr. Harris saw and did in your actual surgery. So please remember to take that in with you at that first appointment, and that just will help your therapist out. Restrictions. So as Dr. Harris replaces your shoulder, there will be certain things that we have to watch out for and protect for while the shoulder is healing. And so for about the first 3 months, we limit what you do with that arm. And that's all to give that the best chance to heal and to give you the best chance to have as much function over the long haul with the shoulder. And so for the first 3 months, we want to limit your lifting and carrying to less than a pound. Same thing, we limit how much you can push or pull to about a pound. And that has to do with not only the replacement, but also the muscles around and some of the other bony prominences in that shoulder that I'll discuss with you more when you come in for that first post-op visit, some specifics with it. But generally speaking, for 3 months, we limit you to a pound on that side. What I really want to talk to you about is not using that arm to get up and down from a seated position. If you use your arms a lot to get up and down now, I want you to start practicing with the other arm and keeping your surgical arm closer to your side and coming up with ways to get up and down. That's where I've seen the most common ways that people can have setbacks after this surgery is putting too much weight on that arm to get up and get down. So practice those things now. As I like to say, start working on your abs, get them stronger. The other thing you'll see on this slide is no falling. And that's one of those that, as silly as it sounds, it is the most common way that people can re-injure themselves. And so being very cautious right out from surgery, being aware of your surroundings. The other thing I'll tell you is having your arm in a sling is something that can make you a little more prone to that. So I want you to be prepared for that mentally. You know, you think about an acrobat. What do they do when they're up on the high wire? They put their hands out for balance. And our hands do kind of give us a little bit of balance there. And with an arm by your side, you lose a little bit of that. So again, being aware of your surroundings, going a little slower, just be more cognizant of that, and do the best you can to try to keep from doing anything that might cause you to fall. And that's just for the first 3 months. We get past 3 months and we'll let you start getting back to most anything and everything that that shoulder will tolerate from there. The other thing I'll say is that, again, expectations. So 3 months we restrict you. I have the expectation that months 4, 5, and 6 are you working to get more motion, more strength, and back to activities, so that most patients are back to 85% of what they were doing before within about 6 months of surgery. But I'll also tell you that almost every patient that I've seen post-operatively will tell me it takes them closer to a year to truly get to as close to 100% as possible. And I say 100%, you're 100%. Our two main goals with your surgery, and Dr. Harris probably mentioned this to you, one is to get back at least the motion and the strength that you have currently, but without pain. What we can't guarantee is that we get more motion and strength. Now, that's on the realistic side. I'm also optimistic. I see too many patients that do better. So I'm not going to set a ceiling for you, but instead, again, focus on the two main things, being without pain and getting at least the function that you have now. So we talked about all the things you shouldn't do, but life doesn't stop just because you had shoulder surgery. So let's talk about the things that are okay to do. And so simple things, typing, writing, all that's good. You can do what you can with limited activity with the arm here. But I don't want you reaching out. And I say I don't want you reaching out. I don't want you reaching out using the muscles to do so, because that can have some negative effect on what was done from the surgery. But you need to know how to do certain things. For example, eating is fine, brushing your teeth is fine. I don't want you here, but here. Now, let's say, guys, you need the arm to shave and this is not good enough. I don't want you to do this, but if you will take and assist the arm and hold it up with something else, then you have access, so that you can do the shaving that you need. Or females, if you'll take the arm and set it on something. That way you've got two hands to help do makeup or do your hair if needed. Now, things like showering. So one, it's a little bit harder in the beginning to get over to the other side. You would think this arm that you had surgery on would be the hardest, but it actually, patients will tell me it's harder to get this side. So you may want to invest in a little scrub brush that helps to reach over there. You may want to invest in spray deodorant because it may be hard to get stick deodorant over there. In the shower, rather than lifting the arm to wash underneath, you can help it and then hold on to something so that you can reach under the arm, or I can get under my arm without moving the arm. I just move the rest of my body. Notice I still have space, but I've not moved my arm at all. It's just moving my body so that I can get down here and wash. So there's ways around it. You just gotta have to, think about how else can I move it without moving it by itself. Okay, so those are a few little simple tricks to try to help make life easier. Even though you may have help, sometimes you want to be able to do things yourself. And the one other thing I want to add that I forgot to talk about when we were talking about pain medicine. So pain medicine is very highly controlled these days as far as even us, the ability to provide them to you. So this needs to be done if you need a refill. And again, hopefully you won't need one, but if you do need a refill, make sure you call during business hours. So Monday through Thursday, 8 to 5, and then Fridays from 8 until noon, to give us a chance, because it has to be done on computer. It has to be sent in a certain way. And so if you're starting to run low, let us know with plenty of time to get that done, because I don't want you to be without if you need it. But it provides, I mean, it's a lot more detail than what you would think to get that pain medicine. So just let us know on that. The last slide is just some information for you, contact lists. Who do I call when I have questions about certain things, and maybe things that I didn't go into deep enough in this presentation. But at the top is our main office number. Then you'll see the TENS unit and cold therapy. If you have any questions about that, want to purchase one, call extension 4023 or 4010. If you have questions about FMLA or return to work papers, that is extension 4020. Questions about the surgery itself, appointments to follow up, or even appointments prior to, call extension 4025. After surgery, questions or concerns, if it's during the day, during working business hours, call extension 4027. That is one of our MAs that works with us, that knows most questions, or most the answers to questions you have. However, if they don't know those answers, they know how to get in contact with us. I do help Dr. Harris with surgery, so I'm not just sitting at a desk, and that she's a good contact point for you to be able to get your questions answered a little quicker. Insurance questions, use extension 4058. And at the very bottom, that's me. I have provided my email address for you. If you have questions that you want me to answer that doesn't necessarily need to be, in a immediate manner, although I do try to check my emails multiple times a day. I even try to check them on the weekends, but I'll be honest, every now and then I kind of forget about it on the weekend. But if it doesn't need an immediate answer, feel free to email me, and I'm happy to try to answer anything I can for you there. I'll also say that if you call the main office number, whether it be nights, weekends, or even during holidays, there's always somebody there to answer your questions. So don't hesitate. If you have questions, please give us a call. We'll try to help you through anything we can. So hopefully this presentation has helped calm some of those fears of the unknown. May have led to more questions. If so, please, don't hesitate to email me or give us a call here at the office, and we'll try to help you through any of those, because again, the main goal of all of this is to try to help prepare you the best we can so this surgery, it goes as smoothly as possible. If you need anything else, let us know. Thank you again for your time, and we'll see you at the time of surgery.